COPD today.
Good topic, and
Yep.
first of all, we'll go over our learning objectives. You need to understand how to initiate and then how to titrate therapy. There's actually a lot of science behind that. I think a lot of people don't use the science associated with that. Realize the importance of non-prescription treatment. Don't just send them home with their inhalers. And then understand how to use oral steroids properly in the treatment of COPD. Okay, take it away.
Okay, so I think we have an article that will be posted. Some of the things I took from the article were things I kind of knew, but they sort of put a point to it. Was 30% of people who smoke get emphysema, but there's many people. Women tend to be more at risk than men for getting the emphysema without the smoking risk factor. And around here, I think occupational exposure, farming is a big thing. And in the developing world, it's like open pit fires.
Yeah,
and
that's true.
Probably getting rid of that stuff is as much to do with us in the United States limiting tuberculosis and these things because we got rid of the emphysema from the occupational exposures. And then the other one was alpha-1 antitrypsin. I've actually got a guy with lung transplant from this, but it sort of is only one little peek into the window of the science in terms of there's anti-inflammatory, pro-inflammatory things going on in the lungs, and alpha-1 is just we're missing one anti-inflammatory, and it can cause huge repercussions.
And that has some treatment implications you wouldn't think about normally, too. We'll talk about later.
Presentation and diagnosis. Cough is a common one. The other one that I liked about this was that I hadn't thought about is dyspnea on exertion. And they made the point that most people don't complain about it.
Yeah, if you're waiting for people to complain about symptoms, you've missed a couple years of treatment and maybe an ability to help kind of slow down progression of the disease. So look at people risk factors, especially occupational things that you might not be asking about. And then, consider PFTs before they complain of symptoms. People attribute, I'm old, I'm out of shape, I should be breathless, this is how people age. They don't necessarily get cough and bronchitis and those kinds of things until much later.
Because it's kind of insidious. We're all losing lung function, but they lose it at a greater rate, but it's just coming on over years, and so they don't necessarily realize how limited they are, and so you want to catch them early, which is I think the one place for PFTs.
Yeah.
Well, there's a couple, but that's a good one, and then PFTs. I think I wish I could remember the quote at the start of the article, but it goes something along the lines of the definition of COPD is like the definition of love. You'll know it when you see it.
Yeah,
but
I
nobody
did like
can quite
that.
agree on it.
That, and I'm not sure people look at it that much. And sometimes I think the guidelines throw us that way. Guidelines make everything look black and white, and COPD is anything but. It's really a heterogeneous disease. And you follow the guidelines, but then you got to use that art of medicine to really apply what's best for patients and how are they responding. Don't give them something and see them back in 6 months.
Right, because there's some people, and I think this is true, that they won't meet sometimes they don't even meet the basic diagnostic criteria by FEV1 to FVC ratio for COPD, but they'll benefit from treatment.
Right.
And then sometimes the response to bronchodilators means something, sometimes it doesn't mean anything.
Yeah.
So it's truly an art of medicine.
Right. And I think the other thing about symptoms is that obstructive sleep apnea is very common in this population, and not necessarily because of what we think of as obesity or body habitus. So think about doing the sleep study. And if you're going to test them for oxygen, don't just trendox them. Do a full sleep study. So make sure you consider that, because you're going to miss some hypoxemia, at nighttime that they aren't demonstrating when they're in the clinic. So.
Great. So now that we don't know what it is, can we agree on we can agree on what the goals are, though.
That's right.
So the goals are to reduce the rate of lung function loss, which is why it's important to try to pick it up early. Prevention of exacerbations. One thing I think we do very well here is immunizations.
Yeah.
Make sure the computer has a good reminder system. It's important for us to ask about triggers, and then Liz isn't standing out there, but smoking cessation. Man, we have resources here, and the pharmacists do a nice job. And smoking cessation isn't just, have you considered stopping smoking? Because they really need somebody to intensively manage it, and there's a consult for pharmacy, and they will call and get on them.
The fact that they have COPD means that they probably have tried to quit unsuccessfully. Everybody knows smoking's bad for you, so they do need that extra support.
Yes.
And sometimes you kind of Well, I'm calling it nagging, but Dr. Chakowski would yell at me because it's motivational. You're doing. It's different.
The nagging is more onerous than the smoking.
Exactly.
They'll offer the medicines too. There's bupropion and Chantix. I didn't realize this, but from the article, supposedly the Chantix is maybe slightly better on meta-analysis, but the confidence intervals were wide.
Yeah.
And I had some people get really kind of bizarre personality changes, anger with the Chantix, so it kind of scares
Nightmares.
me. So I think in that regard, the VA's sort of nicotine replacement plus bupropion.
That works good.
I think that's the way to go, and then the
Yeah.
last ditch is the Chantix. But when that one first came out, there was all kinds of people knocking on our doors.
Right.
And upset that we didn't have it right off the bat. But it was
Yeah.
probably a good thing.
Yeah. I think, looking at really what you're trying to do is improve people's quality of life. That isn't necessarily measurable by repeat PFTs.
Yep.
In fact, trending for that reason probably isn't indicated.
Mhm.
So, again, kind of good history, talking to your patients. But I think one of the biggest things that helps quality of life is pulmonary rehab.
Yeah.
That's big. That's crucial, I think, in people with that have decreased quality of life with that. Because they've already lost, because they've lived with this breathlessness for years. They've also lost physical conditioning, and it's kind of just a downward spiral of the quality of life for them. Then they're got osteoporosis from their smoking, and they're physically deconditioned, and they fall and they break a hip. It's got a lot of things going on with it.
I found out I hadn't had somebody with pulmonary rehab for a while. So it's a non-VA care consult,
Yeah.
and they go to Bergen Mercy. And
They like it.
Yeah, it's a good thing.
They hate it when it runs out.
Yep. Oxygen.
Yeah.
So what do you guys think about oxygen?
Good thing, right?
Good thing. The validation studies were done like on roughly 600 people 40 years ago.
Yeah.
It was revisited recently. And the thought was that probably more people would qualify because people are now sicker, living longer. And it didn't turn out to be true.
Yeah.
So oxygen is extremely expensive. I think the editorialist made a nice comment on this on the oxygen business, in that there will be some people who don't meet the strict criteria, and there should be a way, if they feel better on oxygen, to get them oxygen. But also keep in mind, there may be some people that qualify by our strict criteria that may not get medical benefit, and if it doesn't help with symptoms,
Right.
I don't know if you should continue it. I mean, there's
Right.
clearly some things with pulmonary hypertension, but
Depends on severity of your hypoxemia.
yeah, exactly. So, and then more is probably better.
Yeah.
But and I don't know if you've run into this, but I have several of them who like to take it off,
Yeah.
and the spouse or the loved ones, the family is super stressed out. And,
Yeah.
I tell them it's probably okay, because
Yeah.
the original validation studies looked at like 17 hours a day.
Yeah. That's
So,
good.
I just think they just get tired of it. They get
Yeah.
nosebleeds in the winter. and
Well,
all
they're
that business.
tethered,
Mhm.
that kind of thing.
Yep.
So, all right, on to medications. Now, the other non-prescription type of treatment here is hardly anyone can use inhalers properly, consistently.
Yeah.
And they may learn, and then that actually kind of deteriorates over time. So before you escalate treatment, always have them work with it. One of the things I liked about the article is like preference between MDI and nebulizer is kind of patient preference thing.
Mm-hmm. Yep.
Not anything like, oh, you got to have more severe to have nebulized versus, using an MDI.
Yeah.
And I think if you have things like bad rheumatoid arthritis or something, using a nebulizer is easier than using an MDI. So again, kind of think about those
Yeah,
type of
and I
things.
think they said that if you're hospitalized with a COPD exacerbation, they prefer nebulizer because it's easier to inhale.
Right.
And the VA you can get nebulizer here. They ask that you try the inhaler first, which is reasonable because on a population-based look at it, there was no differences.
Right.
But I do have people that are, for whatever reason, the nebulizer's magic
Helps
for
them
them.
comply more. I
Yep.
think they get some better relief. And again, I'm not even sure I could use an MDI properly.
Yeah, I think with a spacer.
Do you think I could do that?
Yeah, it whistles.
Thank you.
Yeah, you know you did it right.
Right. Right.
So albuterol is our first line.
Yeah.
I can't remember the last time I prescribed Combivent, which is albuterol plus ipratropium.
I think this is where those gold criteria come in, and where you want to be careful about following it too strictly, but actually it's a place to start.
Mm-hmm.
So if you've done your PFTs and the numbers are like 80, 70, 50, 30 for your different types of medications, I see a lot of people get a little bit confused about the difference between long-acting beta agonists and asthma and COPD. So, so if you got mild, using a short-acting, either ipratropium or albuterol is perfect, and they don't show much difference between the two.
Right.
They both are bronchodilators, which is kind of a change from when I trained in the Flintstone era.
Exactly.
But after that, when you get down to a little bit more moderate disease, using a long-acting beta agonist or a tiotropium is your next step, and keeping your rescue inhaler.
Mm-hmm.
A lot of people like to jump to that steroid inhaler because they kind of think, oh yeah, I heard about long-acting beta agonists increase mortality. That's not true in COPD. It's a different disease.
Right.
You want to avoid the steroid until you're like at stage 3.
Right.
Unless you got symptoms. The gold criteria are really pretty good about that. But I think you don't have to memorize those things. It's kind of inherent. Stage your treatment that way, and then if they have symptoms, escalate.
If you do think they have asthma, I also found out you can get a methylcholine challenge test.
Yes, I like that.
Because
I use
actually,
that a
this
lot.
fellow that I have that's doing pulmonary rehab, he's a lifetime non-smoker, but he has fairly profound symptoms.
Yeah.
And so he's getting a methylcholine challenge test, which is a non-VA care consult that goes over UNMC. I haven't got the results yet, but because it changes how
nice
you.
to do. It does.
Yeah.
And your PFTs aren't going to. Your normal PFTs aren't going to tell you that. So.
And I like this is because going down that pathway, I kind of like the LAMAs more than the inhaled corticosteroids.
Yeah.
Although when you read the article, boy, inhaled corticosteroids have some good data behind, not as you slow the decline of lung function.
Yeah. It's that inflammation theory again.
Less hospitalizations, less exacerbations. What are the side effects that you have to worry about? Thrush.
Hoarseness of voice. Hoarseness of the voice.
And pneumonia is a class effect that they brought up.
That's why you want to reserve it for that kind of stage 3 patient, where the benefit and the risks are balanced out at that point.
How about tiotropium is our preferred long-acting. It turns out it's a little bit different in terms of receptors. It's more specific to the lungs, so you don't get as many receptors other places. But what things do you need to worry about? We have a population of old men,
Who have to get up multiple times in the night.
and now they can't go to the bathroom.
It happens a lot. I've seen it a lot.
Yeah. Even though we think it's more selective for the
Right.
lung, you can make BPH worse.
Confusion and all that.
Glaucoma.
Yeah.
You can precipitate that.
Yeah.
But BPH is the worsening of the prostate symptoms is the main one that I've seen.
Right. Right.
Um,
So the article mentioned about an ACE and ARBs and statins all reducing inflammation and lung disease. I don't know. Most
Yeah,
of my
that's-
patients are already on that for another reason.
Exactly.
So I'm not opposed to that.
I don't think I would.
I haven't ever prescribed it
I would. Yeah. Well, I
for
think.
COPD.
I think it'll be a rare bird here
Yeah.
that doesn't
on
already
that.
need those.
They already got coronary arteries
Yeah.
from their
And I don't
COPD.
think I would be like,
Yeah.
I have nothing else to offer, so I'm going to throw a statin. I think I'd send them
Right.
to pulmonary first.
Exactly.
Which is also, I don't know how you feel about theophylline, but my kind of like, where do you make a consult line is at theophylline. Apparently, some people think now it makes you more sensitive to steroids, and so it might be a good idea, but the therapeutic index is
Right. Right.
narrow.
I've used it in special cases. I like it for certain people.
But have you started it, or you asked pulmonary to start?
Not recently. I used to.
Yeah, I haven't done it forever,
Yeah.
and so I'm kind of like, well, that's pulmonary forever.
Yeah.
Because it fell out of favor.
Right. It did.
For a
Now
while.
it's back.
Mm-hmm. Oh, macrolide. Should we talk about that?
Yeah, that's a good idea. There's a
So
lot.
who should get, what about azithromycin? I love azithromycin. It's a great antiviral. Did you guys give him walk-in inappropriately? No.
Yeah,
Uh,
exactly. Cures every cold out there.
Confuse them. They're all gonna imprint that now.
I know. It's the only take-home point they'll get.
Exactly. So they, it's now changed to thrice weekly for severe COPD. You can use the macrolide to prevent exacerbations. What do you guys think about that? who should get it and what's the downsides.
QTC prolongation.
Yeah, it definitely affects QTC.
And then
Mhm.
it's got long-term ototoxicity. Not an insignificant amount of folks will develop problems over a year. Around 8% will lose hearing loss to at least some measurable degree. And so I think it's a great thing, but I also think that, well, you worry about bacterial resistance too, right? Because you're giving them this daily.
Yeah.
And then they're already on inhaled corticosteroids, more likely to get pneumonias, all kinds of stuff. I kind of reserve for those people who I think have significant mortality.
Right. And that they're going in the hospital all the time.
Yeah,
You know, that
exactly.
kind of thing, so.
Yeah, they've had multiple, 5 or 6 exacerbations in a year. It's kind of a, gosh, what was the mortality after? It's fairly high
It's very high.
after an exacerbation.
Yeah.
30% a
Right.
year. So if they've had multiple exacerbations, their mortality is probably high enough to qualify
Right.
for that therapy.
Right. Steroids. What's the optimal dose of steroids for for a patient? Are long-term steroids ever indicated?
No.
No, not anymore. And you're starting to, this used to be a standard practice. And I just remember seeing all those patients with no skin, no bone, hardly anything. So you still might see people, these co-managed patients from like rural areas on long-term steroids, and you
5
really
or 10.
yeah, 5 or
prednisone.
10, or even every other day. Horrible treatment. So the less the better. Still useful. Still useful in the hospital. If you can get away, I mean, data has shown that a 5-day dose of like 40 to 50 milligrams is all you need.
Mm-hmm.
There's the rare bird, maybe the person that hasn't had a methylcholine challenge that can't be treated that way, but really try to reduce the use of your oral steroids and try to get any patient.
Dose and days.
Yeah, and patients often feel better on steroids. There's a mental effect.
Mhm.
You feel more energetic. And so it's sometimes hard to convince them to go off of steroids, but just way bad side effects. So.
Yeah, no reason to do what we did in the bad old days was, rather than recognizing bad disease, we gave more drug at higher doses longer, and we gave them enough steroid to make some of them psychotic.
Yeah, we did.
We gave a lot of steroid.
Yeah.
Multiple of what is given now.
Right. Right, big difference.
Yeah, huge difference. I think that's all I got other than lung reduction.
Yeah,
Or do
you want to talk about lung reduction?
Sure. Lung reduction surgery, I don't know if it's going to be a thing that stays around. You have to be very select, right? You need a pretty significant decrease in your lung functions. You need to have predominantly upper lobe emphysema, and you have to be a pretty good surgical candidate. And now there's probably the pulmonary doctors are getting better with like endobronchial things, like these sort of endobronchial flutter valves and all this.
Those are kind of cool.
They are cool, and so the lung reduction surgery may go away. I've had a couple of people who've had it over the years. It is a major surgery, because think about what you do. You cut off the upper lobe. What happens to the pulmonary vasculature when you snip that thing out? It's like having a PE. I mean, because literally you're just ligating it, and they all get hypotensive intraoperatively. It's not a morbid surgery, although it will benefit a select few.
That's right.
So keep it in mind if you have
And they often
somebody.
don't get referred soon enough. You
Yeah.
can get so severe. You shouldn't be at a stage 4 before you get referred.
Yeah, because you can get so debilitated you
should be
shouldn't
at a
get the
stage.
surgery, because
Yeah.
it is a morbid surgery,
Right.
which may be going away with less invasive techniques via endobronchoscope. But keep in mind it's out there. Lung transplant, they're doing them in town now, and so make a referral.
Yeah. Early.
Yeah, make a referral early. I wish I should know what the criteria is to be listed, but I don't. Like, they have a certain PFT cutoff. I actually honestly don't know, so maybe that's a learning thing for me.
In UNMC's website for transplantation, they have the entire criteria and the guidelines before patients can go into transplantation.
Okay.
Oh, good. Okay, because I know
That's
for
great.
kidneys, there's an easy measure. Their GFR has to be less than 20 before they go for evaluation. So it's nice, easy. If it's not that low, there's no reason to waste your time. But so I guess if you have somebody questioning, we can look it up.
That's good.
Do they have a single criteria, or is it like a? Because with the lung, I'm guessing it's
Sure, but I
harder.
looked it up earlier. They had like all the criteria, not only like PFTs, like social criteria and what all the patients have to have before they can get a transplant.
Right.
So if I find a link, I will forward it.
Okay. Yeah.
Or if you're in
great.
doubt,
We can put it on the
ask
blog.
Dr. Google.
But please don't ask Wikipedia.
Yeah.
It is not Wikipedia. Okay, key points. Use combination of PFTs and symptoms to individualize therapy for each patient. Steroids need to be limited, and then utilize pulmonary rehab and teach and reteach use of MDIs. Our pharmacists are great at that, so
Absolutely.
very patient.
And
They
they're
say I probably can't use it right, so I probably shouldn't be teaching it. So,
and they're a great resource for smoking cessation, which is always good.
yep. All right, that's it.
Okay,
Thank
thanks
you.
guys.